Okay, so I believe the broadcast is on. Yeah, the participants are starting to come.
Perfect.
Okay. Good morning, everyone. We're going to be starting in just a couple minutes. I see that participants are starting to come on the line, and hope you're enjoying the sessions. If you need anything, you can always email me at harold@admcorp.com. I'm more than happy to answer any questions that aren't answered as part of the session. So we have just a couple minutes and we'll begin. Good morning, Dr. Cohen. Okay, well, we're going to begin. Good morning, Dr. Cohen. How are you today?
I'm good. How are you?
Fine. So today we're going to talk about Nevus patterns. We started this last week, and we'll also start melanoma. In 2 weeks, we'll finish melanoma, and we'll show unknowns of Nevus and melanomas. So let's begin. And again, I just want to thank MedOptima for hosting this meeting for us. Aaron Hirsch, I appreciate everything you've done to make this a successful meeting. Just a little bit about references. I would strongly recommend you going to the International Dermoscopy Society website. They have podcasts, as well as they have a Dermoscopedia where you can download images, and it's just an excellent wealth of material. Another question individuals ask me is where to buy your dermatoscopes. Well, you can get a dermatoscope at MedOptima, as well as 3Gen, Heine, as well as Canfeld. And all of these give discounts to residents. Just a reminder, September 12th is the American Dermoscopy meeting. Usually it's held at a different national park. Unfortunately, it was canceled this year, but it'll be a virtual meeting. Ashmar Goob runs the meeting, and in my opinion, it's the best dermoscopy meeting when it's a 4-day course. This, unfortunately, will only be a 1-day course, but it's well worth your time, and it only costs $99. They're actually giving away free prizes, a couple dermatoscopes, as well as some free trips to go to the meeting next year, which is at Zion National Park. Now, yet last week, 2 weeks ago, we finished with congenital nevi. We showed the different patterns. We showed the specific structures, and we're going to continue on with acquired melanocytic nevi. And this is my definition of acquired melanocytic nevi. Clark nevi junctional type, a junctional dysplastic nevus, low-grade, mild to moderate atypia, a lentiginous junctional nevus, Clark-Nevus compound type, compound dysplastic nevus, low grade to mild moderate atypia, and compound nevus. Depending on your dermatopathology determines what it is called. These are all benign lesions. We also have in this category nevi with congenital-like features, or these are nevi which are acquired but have all the classic features of a congenital nevus, which we spoke about last week. So let's begin. Example 2. This 46-year-old woman, recently diagnosed with cancer, had a dark mole on her chest. The structures, what do you see? Well, you have a typical network at the periphery with this central dark structureless area. It's a melanocytic lesion because it has a network. In order for it to be a melanocytic lesion, it either has a network, globules, streaks, homogeneous blue. In this instance, a network. Are there few colors or many colors? 2, light brown and dark brown. Is a lesion symmetric or asymmetric? It's symmetric in pattern, therefore dermoscopically it's a symmetric lesion. In order for it to be a symmetric lesion, you cut it in half this way, you cut it in half this way. The pattern is symmetrical. Does it have any of the features to aid in the diagnosis of melanoma? The answer is no. This is a reticular homogeneous pattern with this central dark area, which we call a blotch. We see this with individuals with Fitzpatrick 4, 5, and 6 skin. And acquired melanocytic nevus. Here we see the bridging of the papilla, the papillary fibrosis. There's no pagetoid spread. Some would call this a Clark nevus because of this perivascular inflammation, the papillary fibrosis. An individual might call this a low-grade dysplastic nevus. It's a benign lesion. And the acquired melanocytic nevi have different patterns. They have a reticular uniform network, a reticular patchy network, a reticular globular, peripheral globular, and reticular homogeneous. So here we have 4 lesions: reticular uniform, reticular patchy, reticular globular, peripheral globular, it's an enlarging lesion, and reticular homogeneous. Blue nevi, example 3. This 33-year-old woman was referred by another dermatologist to have this blue nodule excised. It had been present on her scalp for many years without a change, and she really didn't want to have a large surgical excision. This is what we saw dermoscopically. Is it symmetric? Yes. So dermoscopically, it's a symmetric lesion. It's symmetric in pattern. Are there few colors or many colors? Well, predominantly 2 colors, blue and white. Do you have red with this vasculature, which is a little unusual at the periphery? Structures. Well, we have this blue-white structureless area and these serpentine branch vessels at the periphery. It's a melanocytic lesion because it's homogeneous blue. Does it have any of the features that aid in the diagnosis of melanoma? And the answer is no. So it's a homogeneous pattern. Is it benign or malignant? Well, it's a tough lesion because if it didn't have this vasculature periphery, you would say 100% certainty that this is a blue nevus. But what about this vasculature? Does it have any significance? In this case, no. In fact, there is a spectrum of patterns in blue nevi. The global pattern is homogeneous. It can have colors though. It can have 1 color or 2 colors. Here we see blue-brown. Here we see blue-white and brown-white. And then it can also have 3 colors. It could be multichromatic. And all of these lesions that are multichromatic are tough. And I would biopsy every single one of these because there is a little doubt in terms of the definitive diagnosis. And if there's a question mark, you must biopsy because these are all difficult lesions. So not all blue nevi are small little 3 millimeter papules, which are dark blue. In addition, some of these actually have dermatoscopic structures, such as our case, where you have this vascular pattern at the periphery. And look at this atypical network here, and this has this steel blue color. Not always so easy. And any question mark, you must biopsy. Intradermal nevi. Example 4. This 62-year-old woman had noticed a change in her mole of many years' duration. It's a pink lesion. What about dermoscopically? It's symmetric in pattern, therefore dermoscopically it's a symmetric lesion. When we talk about pattern, we're talking about the contents in terms of its pattern, not the shape. There are 3 colors, pink, white, and brown. Structures, we have this globular pattern in the center, we have a structureless area, and if you look carefully at the vessels, they're fine vessels, many of which are slightly curved. It's melanocytic because there are globules. There are no melanoma-specific features. It has what's called a homogeneous globular pattern, and this is characteristic of an intradermal nevus. And these are all the features that we see with intradermal nevi. Let's take a look at a few. In this case here, we see globules or globular-like structures in a cobblestone pattern, and you have some structureless areas in between these globules. Look at the pattern clinically. It's mammillated. It often has this type of texture to it, which is soft and pebbly. In this case, we have a different pattern. We see this focal network in structureless area. As the lesion increases in size and is dome-shaped, all that you sometimes see is structureless areas with the overlying network superimposed over the lesion. In this particular case, we have globules, we have structureless areas, and we have a network. In this case, and this is a characteristic pattern that one sees for the shades of pink lesion, all that you see is the vasculature. And if you look at the vasculature in this particular case, it's symmetrical throughout, and it also has what we call slightly curved vessels or comma vessels. And it's symmetrical, and this is characteristic of an intradermal nevus, a shade of pink nevi. 2 common types of intradermal nevi are una nevi and Mishra nevi, and both of these are considered either small congenital nevi or nevi with congenital-like features. Here we have an una nevus. It has 2 different types of patterns, a sessile papillomatous and sessile pedunculated. And this is the type of nevus that I often see on truncal areas. It looks as if it's on a stalk. It looks like a papilloma or a skin tag, and yet it's an intradermal nevus. Let's take a look at these dermoscopic patterns. Dermoscopically, we see globules. We have some pale to white structureless areas. We have these linear vessels. The linear vessels tend to be more over the large portion of the lesion, and some focal brown structureless areas. For the pedunculated type, the vasculature often is in lines. And here you can see some of these lines are not lines, but slightly curved vessels as well. Mishra nevi. This is the most common nevus on the face. It's a dome-shaped papular nodule of the face, and often dermoscopically, it can simulate a basal cell carcinoma. And here you can see the features of a Mishra nevus. You see these serpentine or arborizing vessels, which look like a basal cell, but if you notice carefully, the vasculature, the bright serpentine vessels are not in focus. In addition, you often always have this yellowish hue, and sometimes you have a bright yellow rim at the periphery. So here you can see the difference, a basal cell carcinoma, where it's sharply in focus, a Mishra nevus, where it's blurry. Combined melanocytic nevi. Example 5. This 59-year-old man with a history of melanoma had a multicolored pigmented lesion with a gray hue at the periphery. Now, what do we see dermoscopically? Is it symmetric or asymmetric in pattern? It's asymmetric in pattern, therefore dermoscopically, it's an asymmetric lesion. Are there few colors or many colors? There's blue, white, and brown. Structures. You have this blue-white, essentially located. If you notice, you have these little structures, brown structures within the papilla. Those are called target globules. Here we have globules, we have Milli-like cysts, and we have a network. It's a multi-component disorganized pattern. You have an eccentric blotch, one of the melanoma-specific features. And when biopsied, a combined melanocytic nevus. Now, for this particular case, if we go back, you can see structures which are suggestive based on pattern. We see target globules, we see Milli-like cysts. These are features that we see often with a nevus with congenital-like features or a congenital nevus. This throws you off. And this is characteristic of a combined melanocytic nevus. Here one sees the histology, the junctional nested melanocytes with these intradermal nevus cells in the upper mid-dermis, as well as the infiltrate of stellate cells containing melanin. And a combined melanocytic nevus are some of the most difficult lesions to evaluate, both clinically and dermoscopically. A combined nevus is a combination of an acquired or congenital nevus directly associated with a common blue nevus. And the features can include the melanocytic component, where you might have network, globules, or vessels, but it also displays a blue nevus consisting of various shades of a blue structureless area. And here you can see how difficult they can be. Here you have a globular pattern, but this is not dark blue. These are both combined melanocytic nevi. This is a little easier. The vascular is suggestive of an intradermal nevus, and this bluish hue over here is suggestive of a combined melanocytic nevus, but this has a malignant pattern. So you can see why often combined melanocytic nevi are biopsy diagnoses. Epithelioid in spindle cell nevi, Spitz-Reed, example 5. This 23-year-old man developed a new pigmented lesion of his right lower leg of 8 months duration. Well, what do we see? Structures, we have these symmetrical streaks in the form of these pseudopods and this central dark structureless area. And the colors are very, very striking. It's melanocytic because there are streaks. There are 3 colors. There's dark brown, black, and faint gray. It's symmetric in pattern, therefore dermoscopically it's a symmetric lesion and has none of the melanoma-specific features. In this instance, a starburst pattern characteristic of a Reed nevus. Now, the spectrum of the dermatoscopic patterns of epithelioid and spindle cell nevi include the following. Global features characterized by this reticular pattern with thick lines, but note the striking color. A starburst pattern with streaming or streaks. Here we have the starburst pattern with pseudopods. A global pattern characterized by a globular pattern. And a global pattern characterized by a homogeneous pattern, but the color is always this striking grayish black, very, very sharply in focus. And a pattern characterized by what we call tiered globules, globules on top of one another and at the periphery. Pink nevi. Pink, pink, brown, and red lesions often have few dermoscopic structures. As a result, the pattern and morphology of the vessels is important in establishing a diagnosis. Here we see these pink and pink tan brown lesions in individuals with fair skin. And some of the nevi that are associated with these lesions include congenital nevi, superficial and intradermal, nevi with congenital-like features, Clark nevi, and Spitz nevi. Here's a distinct pattern. It's a characteristic pattern that we see with these pink lesions. It's a congenital nevus, and it's characterized by the following. It's characterized by these slightly curved vessels, the common vessels, and these serpentine vessels with this snake-like configuration. We also see polymorphous vessels in a pink lesion with a Mishra nevus, and it's characterized by vessels as dots and these slightly curved vessels. And if you note at the periphery, this is a characteristic feature often seen with Amicia nevus, this golden brown halo at the periphery. Here we have a Clark nevus. It too has polymorphous vessels, and you can see vessels as dots with some slightly curved vessels and perhaps some linear irregular vessels, but the pattern is symmetrical throughout. We look for symmetry. And here we have a Spitz nevus with vessels as dots, as well as these white lines. Balloon cell nevi. I just saw one yesterday, not common. It's characterized dermoscopically by diffuse white globules throughout the lesion and histologically by these balloon cell nests. So here we can see two examples of balloon cell nevi. It's a distinct pattern. You'll see this a couple times a year. Recurrent nevi. Clinically, these neoplasms may simulate melanoma. Dermoscopically, they have distinct features. Now, for recurrent nevi, we see these in younger individuals. The pigmentation is confined to the scar, predominantly, more commonly on the torso. The time to recurrence is about 8 months. It's much, much longer for recurrent melanomas. The growth pattern is centrifugal as opposed to the chaotic pattern that you would see with the melanoma. And the pigment's contiguous as opposed to the non-contiguous pigment that you see with recurrent melanomas. Two other important features, we see the recurrent melanomas in older people, as well as pigmentation traverses the scar's edge, and more commonly seen on the head and neck in terms of recurrent lesions. And this is the characteristic type of lesion you'll see. You'll see a whitish area clinically and a dark area in the center. Dermoscopically, it's characterized by radial lines, symmetry, centrifugal growth pattern, and pigmentation confined to the scar. This one's a little tougher because it looks as if the pigment goes to at least to the edge, perhaps a little beyond it. And in this type of case, what you like to get is the original pathology report. All of these lesions could be avoided if you did appropriate biopsies. Doing these little tangential shave biopsies or shave biopsies with the razor blade, if you go too thin, you'll repigment. So please do your biopsies appropriately. No punch biopsies for these lesions as well. Here we have this particular lesion. We see radial lines, symmetry, centrifugal growth pattern, as well as pigmentation confined to the scar. Halo nevi. The two distinct patterns. We have this homogeneous globular pattern and homogeneous. It's characterized dermoscopically by this symmetric white structureless area with these central dots granules. That's one pattern. Another pattern is, in this case, you can see it has a globular pattern which has been eradicated for the most part. This is the remnants of the nevus, which you can see is a nevus with congenital-like features or congenital nevus. And this is the other pattern. Now, a percent of halo nevi will completely disappear. Here you can see this lesion with the halo completely disappeared and left no residual hypopigmentation. That occurs approximately in less than 10% of patients, but for the most part, you'll have this persistent halo. Finally, patterns where nevi simulate a melanoma. This occurs with traumatized nevi, pink nevi, and the high-grade dysplastic nevi with severe atypia. These are read by some as high-grade dysplastic nevi. Others read these as Clark nevi with unusual features. Some will say that it's a congenital nevi with unusual features. And some will say, these are not nevi, these are early evolving melanomas. And then there are the atypical Spitz nevi. All of these lesions should be completely excised. Anytime you are not sure, excise them all. So these are two traumatized nevi, and yet it has many melanoma-specific features. In this case, you have this blue-white veil. Globules are regularly distributed, a negative pigmented network. white shiny structures. In this case, we have a negative pigmented network. Globules are regularly distributed. Focal vessels as dots. These both have malignant patterns and have all the features of a melanoma. And yet when biopsied, are traumatized nevi. And this usually occurs on the upper shoulders where areas are rubbed or around the belt line. These are the two most common areas that we'll see these traumatized nevi, which have unusual patterns. Pink nevi. Pink and pink-brown nevi that are clinical outliers and demonstrate diffuse vessels as red dots or polymorphous vessels should be completely removed. And here we have a pink lesion here, a pinkish brown lesion. And you can see the two giants. Most of you don't know these names, but two are the world's most prolific dermatopathologists, Bernie Ackerman and Marty Mim. They read it out differently. So even the giants often debate in terms of the ultimate diagnosis. But here we have a spitzoid melanoma, according to Marty Mim, and according to Bernie Ackerman, a spitz nevus. Here we have a spitz nevus. But in this individual here, it was 70 years old. How could it be a spitz nevus? But here you can see the problems. Here we have what was called a high-grade dysplastic nevus. Look at the features. Linear irregular vessels and vessels as dots, polymorphous vessels. Red is a high-grade dysplastic nevus. I'm sure I could get a dermatopathologist to read this in the evolving melanoma in situ. Here we have a lesion that was read as a melanoma in situ. Again, you can see these are very small lesions with the identical pattern, linear irregular vessels and vessels as red dots. Finally, the high-grade dysplastic nevi, the congenital nevi with unusual features, what I call atypical melanocytic nevi. Every single one of these lesions has a malignant pattern. Every one of these lesions should be excised or a broad shave biopsy, but you need to make sure that you have a margin. Every one of these could be melanoma, and yet they're read as atypical melanocytic nevi with various dermatopathology terminology. Okay, so let's move on to the melanoma-specific structures and patterns. And again, thanks to MedOptima, and we approach melanoma patterns the same as we approach nevi. General global patterns will show how specific structures distinguish benign from malignant lesions, and common patterns seen in different types of melanomas. General or global patterns. Years ago, boy, time goes by, back in 2007, Ashmore Gubin and I published this article called The Beauty and the Beast Sign in Dermoscopy. And you can see it was published in Dermatologic Surgery because it was rejected at the Blue Journal, it was rejected from the Archives of Dermatology, the British Journal of Dermatology. But once it was published, it was the leading cited article for that particular year. So the Beauty and the Beast Sign comments the fact that benign nevi display 1 of 11 recurrent dermoscopic patterns, and they fit the definition of beauty, symmetry of pattern, structure, and color. And the recognition of those patterns just helps you distinguish benign and malignant lesions. And we've gone over the common benign patterns. These are the common patterns. In contrast, we have the beast. And the beast deviates from any of the benign patterns. There's an infinite number of patterns, and they invariably display some degree of asymmetry of pattern, color, and structure. So when I'm examining patients and I'm performing dermoscopy, I'll come across a lesion which just doesn't fit the pattern for that particular individual. And it'll give me a little feeling of discomfort. I'll look at it more than once or twice. I have to make a decision in terms of what then needs to be done. And those are the beasts. So this is normal, it's a reticular pattern. This is abnormal, reticular disorganized. Here we have a reticular homogeneous pattern with the central hypopigmentation. Here we have a reticular homogeneous disorganized pattern. Here we have a reticular homogeneous pattern with central hyperpigmentation. Here we have a reticular homogeneous disorganized pattern with eccentric pigmentation. And this type of pattern is often associated, a melanoma in association with a congenital nevus. Here we have homogeneous disorganized. And I showed you this lesion the first session on this lesion, which was either a metastatic melanoma or a dermal melanoma, which is very rare. Globular, congenital nevus, globular disorganized. Reticular globular disorganized. Homogeneous globular, globular with structureless area, you see with the intradermal nevus. Homogeneous globular disorganized. Two component, two kissing lesions. Two component, disorganized, melanoma in association with a congenital nevus. Multi-component, symmetrical in pattern. Multi-component disorganized. And then we spoke last 2 weeks ago about some of the structures to distinguish benign from malignant lesions. And we focused on the structures, and these are the structures that we focused on. We'll only comment on one because it's the same as 2 weeks ago. Benign lesion where the network is uniform, consisting of these hypopigmented holes and light to dark brown lines that fade into the periphery, whereas a malignant pattern, the network's non-uniform, color is asymmetrically distributed and accentuated at the periphery, benign and malignant. And finally, common patterns seen in different types of melanoma. Now, this was an article which was published about 6 years ago, and it was called The Molecular Pathology of Melanoma, an integrated taxonomy of melanocytic neoplasia. I had no clue what that meant, but interpreting it, essentially, Dr. Bastian, who's one of the world's authorities in dermatopathology on melanomas, comments that melanoma subtypes are based on the amount of sun exposure and gene mutations. And this was his classification in terms of epithelium and non-epithelium associated, whether you have high or low ultraviolet light exposure. Still too complicated for me. I try to keep it simple, and this is just sort of an adaptation of Boris Bastian's classification. We have melanomas on chronic sun-damaged skin, and we have in that category the melanomas on sun-damaged skin and desmoplastic melanomas. And then we have the non-sun damaged skin or intermittent sun exposure. These are melanomas and associated with nevi or de novo melanomas, the nodular rapidly growing melanomas, the shades of pink melanomas, spitzoid melanomas, nevoid melanomas. We're not going to be talking about acral, mucosal, or dermal melanomas for this particular lecture, but later on in the year. Let's look at melanomas on sun-damaged skin, the category of chronically sun-exposed skin. We know there's an increased incidence. You can see that from being in South Florida. We see at least 2 of these a week of these melanomas on sun-damaged skin. They're not associated with large number of nevi nor BRAF mutations. 30% are associated with c-KIT mutations and 8% with NRAS. And the clinical features, it's in our older people or older elderly individuals, soy elastosis, actinic keratoses, guttate hypomelanosis, and solar lentiginase. The structures can be subtle. So let's take a look at clinical image of non-facial melanomas. And when I was up at NYU doing my training, we used to see these lesions all the time in individuals over at the Veterans Hospital. So truncal melanomas, subtle lesion, melanoma. That's a melanoma. This little lesion right there. And that's a melanoma. It's an outlier. And that's a melanoma. It's simulating a pigmented actinic keratosis. You can see the scale. All of these are melanomas on sun-damaged skin. And with your eye, you can't make a diagnosis. With dermoscopy, you can. See how this blends in with the rest of the skin? Looks almost as if it's a bruise or post-inflammatory hyperpigmentation. Now, these are the ones you see across the room, but this was a melanoma on sun-damaged skin at one time. Well, why? He has these two melanomas on sun-damaged skin, and you have to assume that other one presented the same way. Well, what about the dermoscopy features of melanoma on sun-damaged skin? Well, there are 4 patterns. Let's take a look at these. Case number 1, 82-year-old woman with a history of non-melanocytic skin cancers had multiple pigmented lesions of the back. Now, this is the one that we're going to focus on, but you can see she has some seborrheic keratosis, perhaps an intradermal nevus over here. This is pattern 1. It's characterized by these islands of pigmentation at the periphery. These islands either consist of network or structureless areas. And in the center, it looks as if it's been punched out. Towards the center, you have these scar-like pink areas. You've got gray dots granules. Those are the regression structures. So the structures are an atypical network, gray dots granules. It's melanocytic because there's a network. There are multiple colors, light brown, dark brown, gray, pink, and white. It's symmetric in pattern, therefore dermoscopically, it's asymmetric in pattern. Therefore, dermoscopically, it's an asymmetric lesion. It has 2 of the melanoma-specific features, an atypical network and gray dots granules. And these are the 2 most common features that we see with melanomas on sun-damaged skin. It's a reticular homogeneous disorganized pattern, a melanoma on sun-damaged skin. Now, melanomas on sun-damaged skin have this distinct pattern where the islands of pigmentation are at the periphery. It's either a network or structureless areas, and the scar-like depigmentation with gray dots granules towards the center. Here we have many examples. Focal peripheral islands, scar-like depigmentation in the center. Focal peripheral islands, scar-like depigmentation in the center. Peripheral islands, scar-like depigmentation in the center. And you can see the islands and the regression structures. And you can see this is a repeatable pattern. So when you see this, you know this is one of the patterns that we see with melanomas on sun-damaged skin. Pattern 2 is the angulated line pattern. Example 2, 82-year-old man, history of melanoma, and lichen planus-like keratosis, developed this faint pigmented lesion of the left arm. It looks like nothing, but dermoscopically, it has a distinct pattern consisting of what we call angulated lines and gray dots granules. So the structures that we see are gray dots granules and angulated lines. There are 3 colors, light brown, dark brown, gray. It's asymmetric in pattern, therefore dermoscopically, it's an asymmetric lesion. And it's a melanoma on sun-damaged skin, malignant type, where you've lost the rete, extensive psorielastosis, where you have these confluent of melanocytes effacing the rete and filling the epidermis. And here you can see some of the pagetoid spread. And there's a question mark in terms of what these angulated lines are due to. I'm still not sure, but supposedly they're due to the confluent melanoma cells at the DE junction with melanophages in the dermis. This really hasn't been worked out particularly well at this moment in time. So this is the angulated line pattern. Angulated lines, they can be in the form of zigzag or as polygons. So here you can see the angulated lines. Angulated lines now forming polygons. angulated lines. Pattern 3, 74-year-old woman with this isolated pigmented lesion of the right arm. And here we see this tan structureless area and granularity. So the structures include these gray dots granules, a melanoma on sun-damaged skin. And this is the third pattern consisting of these tan structureless areas and granularity. You might see occasionally other features, but the most important features are the tan structureless areas and granularity. So here you can see granularity, tan structureless areas, granularity, and that's pattern 3. The final pattern is the most difficult pattern. It's the Lenigo-like pattern, because this pattern simulates what's called a lichen planus-like keratosis. Lichen planus-like keratoses are either a solar lenigo or a seborrheic keratosis that's undergoing regression. And they too can have regression structures. The regression structures you see with melanoma are finer and much finer granules as opposed to the coarse granularity that you see in lichen planus-like keratosis. And you'll learn this in future lectures. But here we see these fine lines slightly curved, short interrupted. This is what we see with the lenigo. There's scallop borders, so that these are difficult lesions and often they're biopsy diagnoses. Here we have another example. This is a lentigo, but the granularity is different. It's finer granularity than you see the lichen planus-like keratosis. In this instance, a melanoma on sun-damaged skin. Could this be a collision tumor of a lentigo and a melanoma on sun-damaged skin? Of course. Here we have another example. And the reason why we have the lines is the rete are intact. In a first blush, you look at this and it looks like a lentigo. But if you zoom in on this particular area, you'll see that in the epidermis, you have pagetoid cells at all levels of the epidermis. This is known as a lentiginous melanoma. What else? Well, this was published just a few years back, talking about prominent skin markings. Here we can see these accentuated skin markings. We actually observed this 15 years ago. We used to call this the blotch sign, the smudge sign, because it looked like a smudge. But this was published, and they're accentuated skin markings. Predominantly see these on the arms and legs, and it has, usually with this type of pattern, it's characterized by either atypical melanocytic proliferation, where diagnosis of melanoma in situ can't yet be made, or melanoma in situ, such as these two cases. And you can see again these accentuated skin markings, and the pathology of these tends to be either atypical melanocytic proliferation or melanoma in situ. Nested melanoma of the elderly, another type of distinct pattern. It's a pattern we see on the lower legs. You shouldn't see a globular pattern in an older individual as an acquired lesion. And this has a distinct pathology. And this was our case, which had the same type of pathology that you see. Desmoplastic melanoma is another type of melanoma on sun-damaged skin. It's not difficult to clinically diagnose. It's impossible to diagnose. And dermoscopically, it's impossible to diagnose as well. It's often a biopsy diagnosis. It appears on sun-damaged skin, especially head and neck. They often present as these firm indurated lesions with ill-defined borders. You know it needs to be biopsied, you just don't know what it is. And this is a case of Dr. Margoub's, this subtle lesion, which seems somewhat firm. Dr. Margoub's, this subtle lesion, which seems somewhat firm. And dermoscopically, you don't see many features. He made out this circle within a circle. I'm not so sure. I could have really picked that out of this lesion. But when biopsied, it was a lenigo malignant with a desmoplastic component. Now, this is very, very important why you don't do superficial shave biopsies of melanocytic lesions. Because if you do a superficial shave biopsy, the biopsy report comes back as a lenigo malignant. You refer it to your Mohs surgeon or your surgical oncologist, or you excise it, or you refer it to a plastic surgeon to excise. And when it's excised, now you come back with a diagnosis of desmoplastic melanoma. And This is the reason why you don't do these superficial thin shade biopsies or razor blade biopsies at a very superficial level for melanocytic lesions. Very important, because this is what will happen, and this does happen.
Harold,
Yes,
sorry, there's a question that I can't answer just because it's, I don't have control of the screen, but
yes,
can you, somebody wanted you to point out the desmoplastic melanoma part of that slide.
yes. That's interposed in between here. These are pleomorphic cells. These are inflammatory cells. These are nevus cells, and for this down here as well. And the important thing is you would need to do immunostains really to pick this up even better. But this is the desmoplastic component here. These cells here, interspersed between this fibrous tissue, or thick tissue here. All right, so moving on. Then we have the melanomas intermittent sun exposure, and there are two different types: melanoma in association with nevi and de novo melanoma. Now, melanoma is associated with intermittent sun exposure. There's an increased incidence of these as well. These are the ones with large number of nevi. 50 to 60% are associated with BRAF mutations, and they tend to be seen in younger patients. Then you have de novo melanomas and melanomas in association with nevi. I think you all realize that most melanomas of intermittent sun exposure are de novo melanomas. Only 30% of melanomas are associated with a pre-existing nevi, and they're about 50-50 split. Everyone thinks that dysplastic nevi is the most common melanoma, nevi associated with melanoma. It's not. It's about 50-50 with nevi with congenital-like features, and we've learned that based on dermoscopy. So let's look at examples of clinical and dermoscopic patterns of melanomas in association with nevi. Here we have this 32-year-old man changing pigmented lesion on the left side of his back. So structures. We see here is a globular pattern with a few terminal hairs. This portion here is a nevus with congenital-like features, or congenital nevus. Here we have the malignant component consisting of streaks, this asymmetric focal dark structureless area with this negative pigmented network. It's melanocytic because there are globules and there are streaks and a network. 3 colors: light brown, dark brown, gray. It does have many melanoma-specific features, and it's a melanoma in association with a compound congenital nevus. Now, melanomas in association with nevi on intermittent sun exposure often have the following features: a negative pigmented network, very, very important, shiny white structures, globules irregularly distributed, and an irregular blotch. Negative pigmented network, globules irregularly distributed. This is a melanoma in association with a pre-existing congenital nevus. Another melanoma association with a pre-existing congenital nevus. You can see here, negative pigmented network, globules irregularly distributed. It's a distinct pattern. Here are 2 more. Negative pigmented network, globules irregularly distributed. In fact, this was an article published a few years back commenting that a negative network is associated with melanomas arising in nevi. Now, we actually did a study, one of my fellows, a couple of years back, and it was a retrospective study of 161 lesions with a negative pigmented network. 35% were melanomas, 17% were high-grade dysplastic nevi, and 3.8% were Spitz nevi. So that's a lot. Of interest also was that you needed at least one additional melanoma-specific feature. At least all the melanomas had at least one additional feature. A third showed a negative pigmented network arising in association with a nevus, which is higher than in the literature. But here are examples. Here we have this subtle lesion on the back. Clinically, I couldn't make that diagnosis. Dermoscopically, you have a negative pigmented network. Here you see the Millie-like cyst. Here's the RCM features and a melanoma association with an intradermal congenital melanocytic nevus. Here we have another example, 70-year-old man. Negative pigmented network. Globules are regularly distributed. Atypical meshwork. Melanoma association with an intradermal congenital melanocytic nevus. This lesion was read by our dermatopathologist as a high-grade dysplastic nevus or congenital nevus with unusual features. It's treated no differently than a melanoma in situ in association with the nevus because it has the same pattern. So for this type of lesion, we normally will either do the appropriate biopsy, but in general, these lesions should have the same margin, in my opinion, as a melanoma in situ. The features, a negative pigmented network, globules are regularly distributed. In that particular case, when reviewed by other dermatopathologists independently, was read as an evolving melanoma in situ. So dermatopathologist only takes us so far, dermoscopy as well, confocal as well. So you have to use your own judgment when managing these patients. Now, the other type of melanoma association with nevus is when you have a irregular blotch. And here we have this patient, and this patient had this lesion. It changed. So this was the original features. Here we can see a globular pattern, lots of Millie-like cysts. This is a pattern we see with a congenital nevus, and you can see the change with this irregular blotch. So the structures include globules, this eccentric dark structureless area. Sometimes we call this a dermoscopic island. A melanoma in association with a congenital nevus. And an article was published quite a few years back talking about these dermoscopic islands, that it's likely, twice as likely to be a melanoma than a nevus, and there is often association between the island of melanoma and the histologic finding of a pre-existing nevus. And here we just have another example demonstrating this dermoscopic island with a melanoma in association with a congenital nevus. Now, a melanoma can occur in association with any type of nevus. In fact, there are investigators, such as Harold Kittler, who's in Vienna, who believe that the most common nevus associated with a melanoma is a small congenital nevus. So we have this young woman with two primary melanomas. This is one, you can see the globular pattern, and this lesion over here with the same type of pattern. 1 month later, she was concerned with this lesion on her shoulder. You can see it's an atypical melanocytic nevus. And interestingly, the pathologists comment on the fact that this particular nevus has foci which, if biopsied by themselves, would strongly suggest the possibility of melanoma in situ. A couple months later, she develops another melanoma in association with a congenital nevus. And this lesion over here, 3 months later, an unusual pattern with a negative pigmented network was read as a atypical melanocytic nevus. And finally, more recently, this lesion over here, another melanoma in association with a congenital nevus. These patients have to be followed very, very carefully. As I mentioned, a melanoma can occur in association with any type of nevus. It's a different pattern with dysplastic nevi or Clark nevi. It's more of a reticular disorganized pattern. This is an atypical network. Here again, another melanoma association with a dysplastic nevus. Different pattern than the pattern that I just showed you with a congenital nevus. Here we see a different pattern again, reticular disorganized with some streaks at the periphery with this dysplastic nevus. And here, another different pattern. Here it's on the ear, and this is the intradermal component of a melanoma in association with an intradermal nevus. I think we're going to stop here, and we'll finish next week, and we'll begin our unknowns on nevi and melanomas. Are there any questions?
Hopefully my comments are not distracting. I guess you don't have to read them if you don't want to. But I'm trying to be helpful. I'm talking to the attendees here, but we've had a couple questions come up, but is there anything else? Let's see. Looking at the Q&A. Oh, here we go. Let's see. In the chat. Oh, okay. Thanks, Ola. Anything in the question and answer? Great. Okay, perfect.
All right.
So, yeah, one thing is just to spread the word. I mean, everybody who's hearing this is on this talk right now, so it's not for you guys, but hopefully we'll just have a fewer amount of emails after this talk asking for us to extend the 24 hours of access. So just please tell your colleagues that they have 24 hours to watch this, the video if they want to see it. And if not, they'll catch it next year, maybe.
Okay.
Great.
Thank you very much.
Thanks, Harold.
Okay. See you in 2 weeks.
Thanks, guys.
Bye, Aaron.
Bye, Erin. Thank you.